All right, welcome back from break. Great robotics session, and you are in for a real treat with Oculomics now. So I am Charles Wykoff, Retina Specialist, Houston, Texas, and it's a privilege to be able to moderate this session with Alan Ho from Philadelphia. So as you are all aware, and we'll learn a lot more about now, Oculomics involves analyzing and predicting human systemic health and disease through analyses of ocular biomarkers. And maybe this first came to our awareness as retina specialists a few years ago when Google published this work in one of the Nature journals. They published that they had trained a deep learning model with about 250,000 retinal images, simple fundus photographs, to predict cardiovascular risk factors. And then they showed in a separate data set that this was highly accurate at predicting things that I, even Alan, humans simply can't predict. Things like age, gender, smoking status, BMI, and specific levels of blood pressure, both systolic and diastolic. Still unclear exactly how these algorithms can actually predict these sorts of things systemically from retinal images alone. Well, since then, the field of oculomics has moved forward tremendously. And now, today, we have an all-star 7-member panel of speakers and panelists who are going to update us on where oculomics is and where it's headed tomorrow. With that, Alan, please introduce our first speaker.
Yes, this is, just to emphasize what Charlie said, this is, I think, a master class considering our speakers here on oculomics. And I think it's a little bit of a difficult concept to understand, but think about data, think about why the eye is special, and think about other data sets that might contribute to not only understanding and treating disease, but understanding and improving wellness. Our first speaker, who's so important to the whole field, is Ali Tafreshi, CEO and President of Topcon Healthcare. Ali.
Well, first of all, thank you very much for the invitation. It's an honor to be up here. What I'm going to talk about is an initiative we call Healthcare from the Eye. And the problem we're trying to solve with Healthcare from the Eye is this fragmented healthcare system where providers are not connected to each other, data is not connected well enough to providers, imaging data is not connected to EMR data, and payers don't have access to all this information. And moreover, because of all this, that we're doing disease management instead of health management. We have poor access to healthcare, and the costs are too high. So Healthcare from the Eye is all about operationalizing oculomics and bringing it into a connected care ecosystem where providers can share information with each other in a meaningful way, and leveraging the eye, not just for eye care, but we believe that eye care will become a central hub for healthcare. And if we can pull this off, then I think we'll be able to solve these problems. Disease management will be transformed into health management and will increase access to healthcare by lowering costs at the same time. Now, how are we going to do it? It's really important if we're going to leverage the eye beyond eye care to make sure that we have automated robotic technologies to capture this data. And that's at the core of what we're trying to achieve here. Make things portable, easier to use, and more cost-effective. And at the same time, there's got to be an underlying software platform and ecosystem of software that allows all of this information to be connected intelligently. But that's still not enough. Topcon can't do everything on its own. So we're all about enabling as many innovators as possible. That's why we set up the Think Ventures to invest in startups. That's why we set up the innovation center called Think to help startups come to market faster and more cost effectively. And then by doing all that, we want to make sure that the platforms connect to all devices, not just Topcon devices, so that we can have multimodal clinical decision support systems. And to take this to another level, it's really important to make sure that we're approaching access through more than just sites that have physicians on site. We need telehealth systems. And finally, I think what's really important is we set up an initiative called IDEA, Institute for Digital Health, to democratize access to as much data as possible so that the AI innovators out there can leverage that information in a way that allows them to bring these insights into the market. So this is kind of like the Apple model here. We have all the devices on the outside. In the center ring, we have the platforms that connects everything. except, unlike Apple, we want to make sure we connect to Samsung phones. So we have a neutral platform. And at the center is making sure we deliver those insights through AI models. But even that's not enough. So I think in order to make this work, it's a very ambitious goal. So we've set up an Alliance for Healthcare from the Eye, who is now officially partnered with CCOI. And this is all about making sure we have the right stakeholders in place that identify the barriers to markets and create the calls to actions in order for us to be able to deliver this in a meaningful way and a scalable way. And this organization is now growing very quickly, and we have participants from different parts of the health system engaging in trying to make sure that we can do this in a diligent and meaningful way. Thank you.
Thank you, Ali. Our next presenter is Cecilia Lee, professor at Washington University of St. Louis, presenting on big data analyses with longitudinal clinical data. Thank you.
Thank you. I see that the PowerPoint is not uploaded, but I'll do my best. Okay. Can I have a... Okay, well, I'm sorry that this was not the PowerPoint that I prepared, but I'm here to show you why Oculomics is important and why now. We are trying to really deliver a new way of approaching our health, really leveraging all the non-invasive data that we can collect from eye and then also the rest of our body. For example, this is an example of visual acuity trajectory. We divided the eyes into the eyes that develop no dementia, Alzheimer's disease, and other dementia such as vascular dementia. And what we are seeing is that an individual trajectory, each line is an individual trajectory of vision, and then seeing, as far as when they're 25 years old to when they're 90 years old. And what we are seeing is that based on almost 155 years of follow-up, those eyes that develop Alzheimer's disease or other dementia, there's a clear inflection point that there's a dip in their visual acuity before they develop other dementia. So this is an important pointer that eye health, not just the visual acuity, but visual function and then the health of the eye is an important marker of their future diseases such as Alzheimer's disease. And I'm going to show you other examples. So right now, when we look at eye data and then other systemic data in terms of whether there is a risk factor for developing dementia or Alzheimer's disease, the fact that somebody has diabetic retinopathy is an important indicator of their future risk of dementia. But what's remarkable is that it is as high as them having a ApoE4 allele, which is the highest or the strongest genetic risk factor known on Alzheimer's disease. And what is really interesting is that diabetic retinopathy was a clear winner compared to them having kidney diseases or blood glucose abnormality. So those are two major complications of diabetes, and still knowing the health of the eye in the retina was a clearer, stronger indicator of them developing dementia or Alzheimer's disease. But we can do so much more in terms of characterizing this diabetes. This is an example of continuous glucose monitoring. This is something that anybody is wearing now, not just the people who are who have diabetes. They're interested in what their body is doing right now. And by characterizing, not just by somebody having a disease or not, we are really characterizing the heterogeneity or each individual person's trajectory in their disease, and we are linking that to the eye data. Environmental pollution is another area of intense interest, and we developed in-house an environmental sensor that is lighter than an iPhone and less than 2 iPhone size together. And this is collecting 22 different environmental data every 5 seconds for 10 days. And this collects such data such as PM 2.5, nitrogen oxide, or volatile gas compounds. And what do we see? This is the data just on PM 2.5, and lo and behold, the PM2.5 that we could sense at their home was directly correlated with their diabetes status. So as we get data such as these that are multimodal, non-invasive, we're talking about new data set as fitness tracking, wearables. We're going to be able to use those combined with eye data to make this Oculomics happen, to really change our paradigm in how we evaluate our disease process, prevent disease, and then also really take care of our health.
Our next speaker is Aaron Lee. Aaron's a retina specialist. He's the chair at WashU. He's a leading big data specialist. We don't want your chairmanship responsibilities to detract from your focus on what's really important, like Oculomics. Aaron.
Thank you, Alan. Thank you so much for this opportunity to present. The effort that Cecilia mentioned called AI-READI, it is hopefully a flagship data set that, for Oculomics that all of you will be interested in. These are my financial disclosures. So AI-READI stands for AI-READI and Exploratory Atlas for Diabetes Insights. And it is a very large project from the NIH where we're trying to build a data set of about 4,000 people that will collect data from head to toe. And the whole point of this effort is to try and build a multimodal data set where all the different elements across the human body are connected and the data elements are interoperable. In particular with retinal imaging, we have OCT, OCTA, color fundus photos. We even have a more experimental imaging device called FLEO from Heidelberg in this data set, and we have multiple vendors across these different modalities. We do things like cognitive function testing as well as doing many different laboratory measurements from their blood. And as you saw, we send them home with a continuous glucose monitoring device and an environmental sensor and a fitness tracker. So all of this data, last year we released our year 2 data set in November. That equated to about 2 terabytes of data of 1,000 participants. In a couple of weeks, we'll be releasing our year 3 data that will have about 2,000 people in it. And all of these numbers will essentially be doubled. I'm going to skip this animation, but this is an infographic that shows you the breakdown of the different people in our data set and how it's distributed across the different modalities. Our project has had sort of a tremendous impact. We have lots of people who have downloaded the data set, and we're starting to see people even publish papers using this data set. So it's starting to have a tremendous impact in the field, and what we're hoping that it will do is actually catalyze the field, because the big problem with Oculomics and AI is that you need data in order to do this, and you can't do it with a couple of health centers. You need to gather large data sets across many different people. One of the things that we spent a lot of time doing in our data set is developing a license that could be used. In particular, we developed a license for this data set that is commercial friendly. So those of you who belong to companies here can download this data set to your computers, train AI models on it, and commercialize them. The license actually permits that. We also spent a lot of time trying to make sure that the data set and the people that we recruit into this study are well representative of the US population, as well as different health states in type 2 diabetes. So none of this would have been possible without the support of all the different PIs that we're leading. If you want to learn more, you can go to our website. That's the QR code. You can register and actually try to download the data set. If you have any trouble with that, please let me know. We want people using this for Oculomics in the future.
Awesome. Thank you, Aaron. Look forward to coming back to that for discussion. The next presenter is Cheung, Professor, Department of Ophthalmology and Visual Science. She's presenting us on Oculomics of brain health in the real world from the Chinese University of Hong Kong. Thank you.
So first of all, I would like to declare that I'm a co-founder of iCognitive Sciences Limited and InnoEye Focus Limited. Dementia is a global public health problem. Having said that, in a recent report of the from Lancet Standing Commission, primary dementia is preventable. Particularly, there are 40 modifiable risk factors, including reduced diabetes, manage cholesterol, stop smoking, and as well as address vision loss. So addressing these risk factors can allow us to prevent nearly 50% of dementia by enhancing brain health in terms of decreased vascular damage, reduce dementia neuropathology, reduce stress and inflammation, and build cognitive and brain reserve. So this can lead us have a better brain cognitive function in order to prevent and delay dementia. So this is a correlation between age and cognitive function. Without any intervention, if we are at risk to have dementia, we will actually develop dementia, particular Alzheimer's disease, which is a major risk factor, which is the major cause of dementia. However, if we can enhance our brain health via optimizing these variable risk factors, there's a chance that we can actually prevent and delay dementia. And even we are developed to mild cognitive impairment or mild dementia. Right now, we have a new drug treatments for early asymptomatic AD. And by enhancing brain health, again, via these modified risk factors, the dementia stage will be delayed. In 2022, my collaborators and I have developed a deep learning model using retinal imaging alone to detect Alzheimer's disease. So we have used 648 patients with Alzheimer's dementia and more than 3,000 subjects with cognitive normal controls. So, and then we externally test this algorithm in 8 centers across 4 countries. So we find that the accuracy is at least 80% in this external validation test. Next question, we would like to ask, how can we translate this innovation to benefit people in real world? So after we conduct a few pilot studies in Hong Kong, we positioned the algorithm into assess brain health by using this algorithm. Particularly those have subject complaints worry of having dementia, desire to prevent dementia, health conscious, health screening, and positive family history. So this is a simple tool that can allow us to assess brain health. For those screen positive, we actually ask them we actually name this is needs attention. So we will recommend them to have a formal cognitive assessment. If the patients are failed in this cognitive assessment test, we will actually recommend them to a formal medical assessment with future workup, for example, a blood test, MRI, and PET, etc. We will again recommend them to reevaluate the control of modified risk factors and ask them to optimize these risk factors. If they are past this cognitive function test, we still highly recommend that they undergo an evaluation of these 80 modified risk factors. For those that screen positive, we will start to educate them what is brain health and avoid and ask everyone to undergo regular retinal assessment to assess brain health regularly. So when we want to deploy this algorithm, we actually construct a cloud-based AI analytic processing platform that allow us to upload the fundus images in real time, and then the cloud, we will process the AI algorithm in the cloud and generate the brain health report. So I know I'm over time, so I'm trying to rush that we have conducted a study in Hong Kong to test this algorithm in a non-demented adults in the community. So we have this study, we have included nearly 900 subjects. For those positive screen tests by using this algorithm, we find that the patients are more older, which and also they have lower education, indicate they have lower cognitive reserve, and the dementia risk score is worse, and the cognitive function test is also worse. And we also find that they have lower socioeconomic status. So we have a coach to coach them to modify their risk factors in this cohort. We hope to generate evidence that by using this simple brain health assessment tool, we can actually enhance optimize their lifestyle intervention and help them to delay and avoid dementia in near future. Thank you so much.
Carol, Ali, Cecilia, Aaron all spoke about retinal imaging as part of a key component of Oculomics for innovation for disease management, but also for your personal wellness, retinal imaging. Our next speaker is a great imaging specialist. He's at Wills Eye. He's a professor of ophthalmology and biomedical engineering, and really a founder of OCT, Joel Schumann. Joel.
Thanks very much, and thank you for having me at this session. I'm going to talk about imaging and AI for Oculomics, and I want to start off with this image from RetFound, which is the foundation model for retinal image assessment. And this is looking both at color photos and at OCT. And on the right-hand side of the image, you can see different categories: ocular diagnoses, prognosis, and then Oculomics. So we're talking about that last panel, the Oculomics panel. And for this, they used a data set for creating the model, and then they used another data set for testing the model. And I'm going to show you some information from that. But what they were looking at using imaging of the eye was at ischemic stroke, myocardial infarction, heart failure, and Parkinson's disease. This is from another paper where you're looking at different portions of the eye that can be imaged. And this isn't just the retina. So you're looking at cornea, even corneal nerves. You're looking at the retina, you're looking at the choroid, and the optic nerve and the retinal nerve fiber layer. There are other components that can be evaluated in this kind of multimodal analysis that will allow us to diagnose systemic disease from imaging of the eye. And here you see some data, again, from still another group, where they're looking at the retinal amyloid index and using curcumin and imaging the curcumin in order to count the number of spots that are present of amyloid in the retina. And then the next graph over on the right is looking at corneal nerve fibers to discriminate mild cognitive impairment and Alzheimer's disease from healthy subjects. And you can see that these discriminations can be made. In the final image on the bottom right, you can see the oxygen consumption being imaged and how that can help discriminate between health and disease. These are qualitative results of the RetFound study that was reported in Nature in 2023. And the top two rows are showing you that the algorithm can regenerate a color fundus image given limited information. So that tells you that the algorithm has learned how the eye is supposed to be structured and how it's able to reconstruct an image from only the squares of information that you see next to the full color fundus image. In the second set of images, the ones labeled B, we're looking at a variety of different diseases, both in the eye and also systemic diseases that are showing us what is being used by the algorithm, what are the salient aspects of the tissue. These are called class activation maps that shows you where the algorithm is actually looking to make these diagnoses, including stroke, Parkinson's, and myocardial infarction. And finally, I wanted to show you these bar graphs that give you an idea of how well this sort of Oculomics AI assessment is working with ocular images. And while the areas under the ROC curves or the prediction response areas are not perfect, they are getting there. So we're able to, with some confidence, identify the presence of these diseases that are systemic by imaging of the eye. The last thing I want to mention, I would be remiss if I didn't mention this, that the Collaborative Community on Ophthalmic Innovation is running these sessions that are AI-driven, virtual online conversations aimed at ending vision loss from diabetes. And these sessions will help to drive consensus by including thousands of people in the discussions. Thank you very much.
Joel, thank you. This next presentation is by Robert Surgott, Professor of Ophthalmology and Neuroscience, Director of Neuro-Ophthalmology, also from Wills Eye Hospital in Philadelphia, making the invisible visible retinal metabolic imaging. Thank you.
Thank you, Charles. It's a true honor to be here, being invited by two of our most disruptive residents, Gil Kleiman and Alan Ho, but disruptors make progress. And most of you in the audience are business disruptors, and this is really a pleasure to do this. I'm going to venture into an area now of physiology as a biomarker, and we will look at fluorescent lifetime imaging ophthalmoscopy. We are partnered with Heidelberg Engineering and OcuScience out of Ann Arbor, Michigan. And what we want to do is enable an earlier diagnosis of all these destructive diseases you just heard about. And I've been trying to teach our residents that for 40 years, and that's why I'm still trying to teach. Okay, so if we look at the history of imaging, over on your left side, you can see all these images dating back to Röntgen, Madame Curie, CT, MRI, the ophthalmoscope, OCT. We have a bone to pick with the Lasker Committee for Joel Schulman, so we're going to do that. But now we're going to move to what PET scanning did for MRI, FLEO will do for OCT. So FLEO is based upon fluorescence. You are all fluorescing out there with endogenous fluorophores. So what we want to do is use those fluorophores without injecting any dye to figure out what's going on with disease. And here you can see examples of that. Let's see. With the FLEO in a healthy eye, a 75 and 69-year-old, and then macular degeneration. Look how much more disease we see. That blue signal means they've lost oxidative phosphorylation. Paul Bernstein and his group at Utah with Lydia Sauer, and then the group at Jena and Bern in Europe, Sebastian Wolf, Chantal Desailly, taught us about this with rare disease, macular telangiectasia, and now Neurocrine has an approved product for this. So better imaging, better clinical trials, identifying disease early will make all your trials more successful and also make life more easy for the regulators. What we're going to do after this then is, and you're starting to hear more and more about this, is tie this to inducible pluripotential stem cells where we can then do what oncologists do. This will really be a biopsy of the retina, biopsy of the brain. Everything you've heard today about the retina will apply to the brain because they're both ectodermal tissue. So mitochondria are going to go from just an energy source to a targetable drug focus. And there are companies out there now doing that in a number of different ways: messenger RNA, nanoparticles, gene therapy. So this will get us to actually biopsy retina and brain with disease, and then after we treat it. So the publications about this are going up immensely. What we're finding is that oxidative phosphorylation changes first. Then we see lysosomal dysfunction. And whether you're talking about what you've heard before, Alzheimer's, Parkinson's, ALS, even neuropsychiatric disease, we're going to use the retina to detect when they start. And we're going to get redox ratios. So we're going to start to intervene for these diseases when physiology changes, not wait for structural change. Thank you very much.
Our next speaker made the questionable decision to celebrate his birthday with us. Happy birthday, Dr. David Rue, who's Global Chief Medical Officer at Microsoft, an internal medicine specialist, an infectious disease specialist, a computer aficionado. He knows a little bit about digital health. David.
Yeah, thank you. For the next 4 minutes, I'm going to try to describe for you 4 major trends that we're seeing in AI, and hopefully this will give you some context in terms of where we're going. The first is that we oftentimes use AI just to diagnose or try to make a diagnosis using the images, but what we're finding is that it's more than just diagnosis that we need. We need to know what's the risk of the individual, what's the prediction of whether or not they will actually have a certain progression. So to understand how you go from just a diagnosis to risk stratification and prediction, we actually need more data sets. Data sets that go beyond just adding more numbers, but data sets that encompass other aspects of one's care. The outcomes, the longitudinal outcomes. We need to understand demographics. We need to understand medications. We need to understand all the different things, including one's genomics. So we're moving away from what we refer to as unimodal AI, where we have single sources of data, to multimodal. And the multimodal gives us a greater diversity of information, but there's a lot of challenges that we see when we start bringing all these data sets together. And this is something that we're now also starting to recognize, that we need to have new tools that allow us to be able to sort out all these different challenges. So one of those tools is the ability for us to start thinking about how, rather than using one model to solve everything, we use what are called agents. So to give you an idea of what an agent is, think of right now the inputs that come in are from multiple different sources. It could be from the environment, it could be from the user, it could be from another agent. And then within the agent itself, which is consisting of a large language model, it consists with protocols and a variety of other types of tools, it then synthesizes that, then it acts on it. And it acts on it by providing information or performing an action. And what we've seen is that when you organize it or you apply agents, we can actually use agents not as a single tool, but also as a potentially well-orchestrated tool. So we have now agents that can just look at images from the eye, images from the chest x-ray, we can look at pathology images, and all of those agents can then work together. So how does that help us? Well, I'm going to give you an example, and this hopefully gives you a sense of how agents can work. So one of the most complicated things we have in healthcare is the diagnosis process. If a patient comes in with multiple things going on, how do we actually understand what's going on? Well, traditionally, the very first thing that we found is that each clinician uses their own internal judgment. Well, if we were to break that down into key steps, what we found is that when we took, and this was based off of 300 New England Journal case studies, we brought this into a model, we created a series of agents, that if we were to bring this together and use multi-agents, we could actually outperform clinicians. Clinicians, when they performed on these tests, they scored about 20%. The agents in collaboration scored around 85%. And what we realized is that the performance for agents working together can be quite extraordinary. And what we've now realized is that when you break it down, it's not one model that's solving it, it's actually a series of models. The first agent thinks of what the differential diagnosis is. The second agent thinks of all the possible tests that can be ordered. The third agent thinks about all the potential guidelines that are concordant with those tests. The fourth agent looks at the cost effectiveness of that, and the fifth thinks about what kind of gaps we may have missed, quality gaps, other things that we are missing. And it's all those agents working together in a collaborative manner that allows us to be able to get to the higher results. Now, that's not the only thing that we're starting to realize. We're starting to realize that if agents could just do all of that, then we would have no need for humans. But the reality is that there are many decision points throughout this that humans have to make a decision. So we've applied this in complicated scenarios like tumor boards, where we've now recognized that in order for this to be something that is very useful and helpful, the decisions need to be made by not only just one individual, but multiple individuals. I'll just give you like one final thought. when you have a treatment option that has higher efficacy but potentially higher cost, but maybe lower quality of life, and you weigh that against another option that has higher quality of life but lower life expectancy but higher cost, these variables are things that only humans can decide, because it's not a computer that can figure all these things out. That's why it's essential that we marry the AI with the humans and ultimately allow us to be able to achieve better health outcomes. Thank you very much.
Thank you. Great presentation. Okay, let's jump into discussion. So Aaron and Cecilia, I'm going to come straight to you guys. You guys have created something incredibly unique. I mean, one of the biggest problems with innovation is that data becomes siloed so quickly for so many reasons. But here you've intentionally created something that's essentially an open source data model. Where did you get the funding for that? What's the vision for that? And how do you get people to contribute if they have no power over what happens to the data and everybody else can use it?
Yep, so those are great questions. So the funding for this came from the National Institutes of Health. The NIH realized that one of the big problems in the field of medical AI is the lack of good data sets that people can use to train models. I think everybody who has trained models sort of had been at the victim of the data sets that they had available to them at their health systems, and those have inherent biases that are built inside of them. And so the NIH wanted brand new data sets created from scratch as part of this. And so our effort actually was awarded at the level of $32 million to execute in 4 years to create this data set. And it was a tremendous amount of work to do it. Now, we are consenting prospectively all the participants about exactly what's happening with their data. So they are completely aware of what's happening to their eye images, for instance. And so that was a really key part of how we were able to get this going. But really, it was meant to catalyze the field and take away one of the biggest barriers in medical AI is the availability of large data sets.
Kudos to building that.
The NEI just awarded in the Bridge to AI competition, I think, an award. There was a press release basically for your work. So congratulations on creating open source data. I have a question for Ali. You talked about all the different spokes, really, and trying to connect all the important components of using healthcare from the eye. Our images, not only in the retina and OCT, but Joel Schumann talked about corneal nerve fibers. How do you begin to start that mission?
So I think the first step is making sure that there's alignment at the very top of within one organization, but also across different organizations, such as what CCOI is doing, making sure that we're making data interoperable, accessible, transparent. That's really important. Making sure you have the platforms, environments that are able to deploy this independent of which device manufacturer is generating the information, which EMR is generating the information. It's a risky move from a commercial entity to go all in on becoming a vendor-inclusive ecosystem, because how do you make sure that your hardware stays at the front and center of things? So to do that, I think you got to make commercialization all about transparency, meaning it's not about who has the best data, the best devices, who can operationalize it and deliver it and scale it in a meaningful way, most effectively.
And the stakes are high. We're not just talking about ocular disease management. We're talking about all the systemic diseases that were given as potential use case examples or real use examples like Carol spoke about.
David, question for you. You have sort of the most external perspective of everyone on the panel, right? The global CMO for healthcare, Microsoft. When you look at ophthalmology, retina, glaucoma, all of us combined, what is it that we could do better as a field to innovate and to leverage our imaging systems to move this field of oculomics forward?
I think most of us are well aware that the eye is the portal to your entire body, and it gives us an opportunity to know what's going on even before the individual does. And that role of being the steward of that information and being able to capture that is really what all of us are here for, because we now have an ability to help lead in so many different areas. We can apply this in underserved and rural communities across the country and the globe
to help individuals that have no access to care now deliver it through the robotics and the mechanisms we have today in a way that's cost efficient and scalable. So this is extraordinary, and this is part of the reason why Microsoft's involved, because we believe that these type of technologies need to be democratized and allow us to be able to have patients benefit no matter where they're at. And the role of the ophthalmologist, the role of the eye care specialist, the role of companies that are in this space is essential, because you're the front end of how we capture that information and bring it into the systems that are so complicated that we have to now understand, when you find these individuals, how do you better manage them? The challenge we have is actually not, at this point, finding the disease. It's about how do you manage all the patients that have the disease with limited resources. And so then what we're now doing is, as I mentioned before, risk stratification, we're doing triage, and we're doing capacity building. And all of those are additional components of the Alliance for Healthcare from the Eye. But at the front, at the center, is going to be the eye care specialist.
You mentioned, everyone mentioned different data sources. I like the way Cecilia talked about it, head to toe. We are privileged to derive significant data from retinal and OCT images or corneal nerve fiber layers. And David, you also talked about other imaging in the body, and you're alluding to other data sets like environmental forces or social determinants of healthcare. All of this depends on AI. But AI can hallucinate. So how do we minimize hallucinations in looking at these very diverse and deep data sets?
For me?
Yeah.
Okay. Yeah. Well, I think when we think of hallucinations, we oftentimes associate that with the generative AI, the large language models. There are many other types of AI developments that don't have the issue of hallucinations. And so it's very important for us to know what type of AI is being applied. But even when we talk about large language models, as I was just sharing before, if you think about an LLM being part of an agent where you have some very specific guardrails and instructions and very specific tasks, you can minimize, if not completely negate, those issues. And so that's part of what we're now realizing. It's not about one type of AI, one homogeneous AI that solves everything. It's about understanding which type of AI to apply, and then how to effectively put those guardrails and safeguards to ensure that not only hallucinations are eliminated, but also that we've enhanced the quality of the outputs and that we've mitigated all biases.
So fascinating. So the democratization of healthcare, love that. So Ollie, I'm going to come to you with that, right? So we have access to great imaging across the eye for served areas. What about the underserved areas globally? How do we democratize? If eye is the tip of the spear, that still depends on getting an eye image. You still have to get an OCT or a fundus photograph or something to put into the system. So how do you do that in underserved areas?
Make devices very easy, cheap, and portable so that they can be deployed and you don't have to worry about them breaking, and they can be commoditized as well, right? If you want to commoditize and democratize data, you got to commoditize the technologies that capture the data and make sure that they're being fed into environments, data environments that can be easily accessible, like the AI-READI Dataset is doing. So I think it's really all about democratizing access to data and democratizing how the data is captured.
Bob?
That democratization really takes partnerships. For example, the Gates Foundation funded our small eye-brain area to go to Nigeria, 90 miles outside of Lagos, and Heidelberg donated an OCT machine. And this was to look at patients at high risk for malaria, HIV, and tuberculosis, diseases that are endemic in that area. So it's going to take industry, it's going to take foundations, and it's still going to take clinicians, and then merging that into larger data sets. So it's why everybody in this room is together, because we're all going to have a role in this democratization of healthcare, but it's not going to be just one of us that does it, it's going to be the partnership.
Aaron, you talked about open source data, and I'm very proud for ophthalmology to be a rich data source for that. Thank you. You talked about consent. All the individuals in the AI-READI dataset, 4,000 individuals, all consented. We all now wear a lot of personalized devices. Where do we, should we, as wearing a watch or an Oura ring, where should we be concerned about our data, or shouldn't we be?
That's a great question. I'm not sure I'm the right person to answer that. Maybe David might be, because he's from industry. But I think that in many ways, like, the American public has sort of decided that they're okay with signing off on their privacy when it comes to digital data. A lot of these big tech companies have already harvested a lot of the data that exists in emails, search results, all the digital behavior. All of that has already been harvested and used, and the American public is not writing about them. And I think with wearables, when Google bought Fitbit, there was a pretty, the privacy groups raised alarm, but the American public didn't blink. And so I do think at a certain level, we need to be worried about this, especially with the rise of like smart glasses that Meta has, where they're supposed to be taking like a picture every couple seconds throughout somebody's life. There's obviously going to be privacy concerns with these things as they move forward. But I'm not sure if I'm the right person to be able to answer that.
Guardrails to be determined.
So Carol, I'm going to come to you with a question. You've built an elegant and impressive algorithm that's detecting evidence of Alzheimer's from retinal imaging. You know, a lot of people are building their own algorithms. There's algorithm proliferation out there. It's easier and easier with different AI systems to build algorithms. What do you do at that stage? For the people in the audience that have built an algorithm and they're interested in moving it forward, you know, are you looking to get this commercial ready where it can be regulatory approved and used broadly to predict Alzheimer's, or are you still optimizing the algorithm? What's your path forward from here?
Those are very great questions. So first, I think in order to improve the development, not just our group, for other groups as well, so it is urged to have a benchmark data set for further validation. So, I think also the output of the model is very important. Although our model is trained from patients with Alzheimer's disease, but it is not going for use as a diagnostic tool. So this have been discussed for a long time. So it's not going to be a biomarker, but it will be an assessment tool to assess brain health in a capture more early stages before it develops to dementia. So this is what I have been gone through for how to position that. And then I think we also developed, like what David have mentioned, how large language models and AI agents can be incorporated to also to enhance the healthcare pathway as well.
And last question, Cecilia and Joel. What's our most near-term use case for Oculomics?
I actually think that the eye imaging has really good performance in characterizing cardiovascular disease. I actually think that is more near term than really delineating all the types of neurodegenerative diseases. And it has a remarkable performance, and they are already being used in cardiology offices. And I think that this Oculomics approach, really anchoring the eye data, retinal imaging data as the anchoring point, but as we understand and process a lot more multimodal data, I think it's going to really revolutionize the way we think about our systemic health, how the eye is related to the rest of the body, but then how we can just manage and really prevent the disease instead of just treating it.
Joel?
Yeah, I would say that there's not just one best use case, and I would agree with Cecilia that cardiovascular disease is an excellent use case. But I do think that neurodegenerative diseases, being glaucoma specialist, would be something important. And looking at Parkinson's and Alzheimer's, I think if you can identify the disease a little bit earlier, that it becomes easier to treat. And also, if you can prognosticate what the trajectory is going to be, it's going to be important for the patient and their family.
With that, thank you. Please help me thank our all-star panelists.